You know Sri Lanka? I climbed up the tower there, Sirigura, which is 600 feet up to the top. I've always been fond of the water, and I did a lot of yachting when I was young as well. Another part of my misspent youth. My name is John Dennerly. I'm 102 and a half. I was born at an early age, before World War I, in Denton, Manchester. I've had a relatively easy life, even with the RAF 5 years of war. It was an adventure more than a penalty, even amongst the bombs. But I wasted a lot of time, my childhood, entertainment, that sort of thing. Even staying up till sometimes right through from midnight right through to breakfast time, and Mother would come down in the morning and say, "Haven't you been to bed, John?" And I'd say, "No, I've been listening to the Schenectady, New York on the radio with the jazz." Enjoyed it. And then sort of settled down once I became a pharmacist.
I don't feel any older than I was, 20, 30 years ago, except with my limitations.
I don't feel 29, but say 79, 69, 79.
I'm not going yet. I'm still strong. I'm very, very strong. I've never realized how strong I am. It's all the food that my mother cooked and first of all grew in the garden.
I make my own bread by hand. I'll probably be making some today.
That's my online. Tesco's coming tomorrow.
We always had fresh food when we were youngsters. Always. Straight from the garden into the pan and onto the plate.
Skim milk, kitchen towels.
6 ounces of flour, 2 ounces of sugar, and 6 ounces of
butter.
Butter.
Apples or gooseberries, lots of gooseberries.
Shepherd's pie.
I don't have many failures. If I'm making a cake and it fails, it becomes a pudding.
Oh, my marriage was absolutely wonderful, heavenly, heavenly, heavenly. I lived with him from the age of 16 until he died at I think it was over 70. I wanted to marry a handsome man and a man with good manners, and I had both.
We did have problems, but we got through them. And I think nowadays people give up too easily.
I'm always optimistic, and she was always pessimistic. So we got on very well together.
Make the most of it, because that's especially if it's the first love. There's nothing like it. When I had my first children, I had twins, but unfortunately, I lost the twins, and that was the most tragic moment in my life. But I had a daughter, and I enjoyed her company very much indeed. Loved her immensely. When I lost my first baby, because one of the twins went, I was devastated. Eventually, of course, you get used to it, because life goes on regardless. You get to feel it, and but you never forget. So it's really wonderful to have something left behind, even if they are no longer here. They're there. They're in your mind. They're in your air, all around you. It's really a wonderful, wonderful feeling. I think a lot of my children, even today, after all these years, I can still sit here and I can talk to them and as if they were still alive. When people pass this way, they hear me talking to my son. They think I'm playing crackers. But I'm not crackers. I'm just thinking about my children. Any regrets? None. None whatever. I can tell you right from my heart. None whatever.
If I'd have been more attentive at school in my early life, I'd have studied more and harder. And although I didn't do too bad in the end. Then I think the sooner you start studying, the better.
I was ill at college, and my father came to collect me, and I didn't want to go back with him. I wanted to stay at the college with the friends.
Hello, Hera. Hera, are you there?
Hi, John.
How you doing?
I'm good. How are you?
Let's see, I can't see your picture here. Let me get on. I hope I'm coming in. Hello, Hera.
Hi. How are you?
Good,
Long
good.
time, John.
Yeah, been a while, huh? And
Yeah.
you're now, are you a Canadian yet?
Yeah, a year to go.
How you doing?
I'm good. How are
No, that's a wonderful part of the world, as you know.
Yeah, John. I can hear the
Yeah,
voice.
yeah, I took that off
Yeah, yeah.
the background. So what's going on? What are we doing here?
We're just starting in maybe 3 minutes. We have Professor Ari Chaco with us with cases, and then we'll be joined by Pablo. He will be giving a brief discussion on his cases. We're just waiting for the faculty to join us. Dr. Ipe is not here yet. Let
Okay,
him come.
what's the first thing? Yeah, you're gonna run the show, right?
Yeah, kind of.
Okay, so you
I'll be
run it,
moderating
and remember time.
Yeah,
Unfortunately, so do the best you can.
yeah. We'll just try to wind this up in 2 hours, or less than that. 20 minutes for each case. I'll just monitor the time.
Okay. Well, sometimes you can ramble a little bit. So, you see moderates, some are really good at it. They delicately steer things off, some are really good.
So let me just do some prep, and then Ankush, do we have you here?
Yep, I'm here.
Oh, okay, good.
Okay, I wrote Ipe a note. I guess he's on his way, right?
Hi, Nikunj.
Nikunj, bhai sahab, how are you, man?
I'm good, Baga. How are you?
Good, good. All well.
We have Professor Ari
Good
Chaco
morning.
with us.
Good,
He's joined in.
Hi, hello there,
Hello.
Hira,
Good evening. Good evening.
Nikunj.
good evening, sir.
Nice to see you.
Same here, sir.
You look like you're sitting inside the mic, inside the video camera.
Okay, sir. I'll just zoom it out.
Right.
There's Ipe.
Hey, John.
Hey, Ipe, how you doing?
Pretty good, John. Everything good?
Yep. We had a good ACNS conference. It went well, very well.
Yeah. So, yeah, I couldn't join in because I was in a product. I mean, in one of those authors meeting with the TV companies. So that's
Yeah,
why.
Ahmad came, Kazadi came. It was really good.
Okay. Yeah. So we.
Hello, Professor
Yeah,
Cherian. Hi.
don't you लेके जाओ.
We're going to start the discussion in another 2 minutes, right?
Yeah. We have Professor Ari with us. We have Ankush with us. So we start with his cases, and then we
Yeah.
proceed as Pablo joins us. So we will start with Professor Ari right away.
How do we know who else is on the panel so I can ask questions?
We you can change the view of the
No, is
panel.
there anybody else around? Who else is on now?
Well, Professor Takashi Kon is there.
I'm sorry?
Professor Takashi Kon is there, if I'm not mistaken. Professor Takashi is there.
Yes.
Yeah, okay, we're gonna start. You guys ready? Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We're honored to help start Ignite, and Hera is going to explain all about it. I'll turn it over to her. Hi, Hera.
John, thank you for arranging this. Thank you, Neurosurgical TV, for becoming our broadcasting partners. We have launched Ignite on July 3rd. Because this is a journal which is not very conventional, so we wanted to add some different features to its educational contents. This webinar is a continuation of issue 1, where we have highlighted the intra-axial lesions of the frontal lobe. We put in 6 cases in our published journal on the web, and today we have the contributors of these cases who will be talking more about them. We have a good panel of faculty who will be giving their views on those cases, anything different that could have been done, what would their approaches be. So we are joined today by Professor Ari Chaco. He has been a tremendous editor and a very good contributor for our journal. Professor Ari is from CMC Vellore, and he has contributed 3 cases to this journal. I would like to request Professor Ari and Dr. Ankush Gupta, who is with him, colleague, to present their cases. We will be following a very strict time format, 5 minutes for case presentations, 15 minutes for open discussions with the panel, and questions will be followed on the Q&A. For anyone who wants to ask, they could just type in the questions, and I will try my best to entertain all of them. If we are not able to do it in time, we could take those questions later and we will put them up on our website. So, Professor Ari, could you please start with the cases?
Thank you, Hira. So what we're going to do is that Ankush will present the cases in a short fashion, and then I will interrupt him intermittently, and we can have a discussion. So Ankush will share his screen.
Yeah, so shall I start, sir?
Yeah, please go ahead.
Yes.
Okay, so the first case that we'll be discussing is a 22-year-old girl who was incidentally detected to have a left frontal mass when she underwent a CT scan of the brain following a mild head injury. She did not have any history of seizures or any focal neurological deficits at presentation. She also did not have any features of raised intracranial pressure. So in this image, we can see an axial T2 MR image, which shows a hyper intense, well circumscribed tumor measuring nearly 2.5 centimeters in size, located in the region of the inferior frontal gyrus.
Your volume is a little low.
Located in the region of the inferior frontal gyrus on the left side. As you can see in this picture, we can see the anterior limb of the internal capsule marked with the green arrow. We can see the external capsule marked with the blue arrow, which seems to be pushed medially. And tracing it superiorly, the junction of the internal and external capsules is the region of the corona radiata, which is shown by the red arrow and seems again to be displaced medially. Marked in yellow here is the precentral sulcus, which is located just posterior to the tumor. The flare image again shows, just confirms this to be a well circumscribed hyperintense mass in the left inferior frontal gyrus. The T2 coronal image shows the lesion to be completely located within the inferior frontal gyrus, as we can see the inferior frontal sulcus, which is limiting the tumor superiorly. And again seen on this image is the corona radiata marked in red, the internal capsule marked in green, and the external capsule marked in blue. And this is the marking of the sylvian fissure. So we can see the inferior frontal sulcus just superior to the tumor. That would be the region of the superior frontal sulcus. Based on these images, we still cannot be 100% sure whether this tumor is located in the Broca's area. So we then proceeded with the T1 sagittal MRI, which quite clearly shows here the white arrow shows the marking of the pars triangularis, which is bound anteriorly by the anterior horizontal ramus of the sylvian fissure. bound posteriorly by the anterior ascending ramus of the sylvian fissure. And just posterior to that, we can see the pars opercularis, which is marked in red over here. So this tumor seems to be located just deeper to the pars opercularis and slightly superiorly. They were maybe displacing the pars opercularis slightly inferiorly. Also depicted in this figure is the projection of the insula, which is a triangular shape on a two-dimensional image, and also the projection of the arcuate fasciculus, shown in yellow over here, which would be connecting the inferior frontal gyrus to the superior temporal gyrus on the same side.
So I just want to stop you there, Ankush. If you just show that
Yes,
image
sir.
again, this is one thing that we picked up from Abida and Pablo, where the arcuate fasciculus, I've always been a little confused about its location. I always thought it would, kind of skirt the insula and lie in the extreme capsule. But here it's quite clear that the arcuate fasciculus lies in the white matter deep to the frontal and parietal opercular. So they're under the frontal, and that is the motor gyrus and the sensory gyri. And here you have these fibers sweeping from the posterior temporal behind the insula, deep to the sensory gyrus, deep to the motor gyrus, and then gets into the inferior frontal gyrus in the motor speech area. So that's something that new that I picked up. It's nicely shown on this image. Yeah, go ahead.
So considering this lesion to be an intraaxial tumor, well circumscribed with no
Volume's gone down again.
considering this to be a T2 hyperintense, well localized, well circumscribed intraaxial tumor in a young lady with no neurological deficits, no perilesional edema, the probable radiological differential would be that of a low-grade glioma, like a pilocytic astrocytoma or a ganglioglioma. So we did discuss the option.
So here the question for people on the panel would be, would you follow this patient up with annual imaging or would you operate? If there's anybody in the vicinity. Hello, Dr. Goel. Right. Nobody seems to be taking
Dr. Goel, he's trying. Go to Dr. Goel, he cannot hear you.
All right. So we thought that since it was well circumscribed, that it was a pilocytic astrocytoma, and we have a problem over here in terms of follow-up. Many patients get lost to follow-up and they don't come back. And so we decided to operate, even though she is actually at a very low risk. We don't have a histological diagnosis, but radiologically it looks like a pilocytic astrocytoma. She's young, she has no symptoms, incidentally detected, and it's only 2.5 centimeters in size. But we decided to go ahead and operate. So what did you find, Ankush?
Yeah, so here we performed a left frontal awake craniotomy, and we were able to achieve a radical excision of the tumor along with the help of neuronavigation as well. Soon after opening the dura, actually we stimulated the gyrus just anterior inferior to the tumor, and the patient developed a speech arrest. So we then stayed away from that region and we stayed within the tumor, internally debulked it, and were able to achieve a radical excision. The patient did not have any intraoperative inadvertent events, and also did not have any deficits postoperatively. Her language function preoperatively and postoperatively remained good. The biopsy of this tumor was reported as a pilocytic astrocytoma, and because of a radical excision, we advise annual follow-up. So this is an image, a T2 flare image done 1 year postoperatively, which just shows a small gliotic scar in the region of the operative cavity. This patient actually, unfortunately, presented with a flurry of seizures 1 year after the surgery. But we were able to control those with adequate medications, and she remains well following that.
Professor Atul Goyal is here. Professor Pablo Gonzalez, And Professor Polo Kadri from the Yasagil's group is here. So I would like all three of them, Professor Goel and Pablo and Polo Kadri, to be commenting on this case if they can.
Hi, this is Pablo. I don't know if you can hear me.
Yes, Pablo, I can hear you.
I'm sorry about my delay. I'm leaving one clinic and going to the other one, but I was able to see it, and I'd like to know if you did a wake craniotomy and you found the speech arrest. I didn't catch it if it was anterior or posterior to the glioma, Ari, and
It was posterior inferior. The speech
posterior
area was
inferior.
posterior inferior, yeah.
Posterior inferior. So it was a little bit anterior to so-called pars opercularis, close to pars
Right.
triangularis tumor. And you found some speech arrest in the subcortical stimulation also?
No,
You
only on
guided
the
your-
cortex.
Okay, so you guided your resection mainly with cortical stimulation.
That's right.
Okay.
So our strategy was to stay inside the tumor and not kind of develop a plane around it.
Yeah, but as you were mentioning the arcuate fascicle.
Yes. I think we've lost Pablo.
The cortical area of the speech arrest could be anterior to the tumor. Maybe the subcortical stimulation would be, let's say, quite interesting to know how deep you can go in your resection. I don't know if I'm right with what I'm saying, because if the tumor is posterior to the speech arrest area, some arcuate fibers are supposed to be deep to the tumor, connecting that area with the parietal one.
Yes, I agree with you. If the tumor is posterior to the speech arrest, then we're dealing with a very dangerous tumor. In this situation, we were lucky that the tumor was anterior to the speech arrest. So we missed
Nice.
the arcuate fasciculus. But I was telling the other guys about the knowledge of the arcuate fasciculus in the white matter of the operculum, not really in the insula. That was something new for me.
Yeah.
So the
Very good.
question to you, Pablo, is, or Dr. Paulo Kadri, is here we operated on this patient who was completely asymptomatic. It's a small tumor and she's young. It's a pilocytic astrocytoma. And yet she developed a flurry of seizures 1 year after surgery when we tried to taper the anticonvulsants. And that's something that we were trying to avoid in the first place. So here we created a new problem when she didn't have a problem in the first place. So what are the strategies that you use to avoid postoperative seizures? Are there any tricks in the dissection or in the hemostasis that would prevent these seizures?
Maybe Paulo can help. I personally don't have anything based on science, but Paulo, hello.
Hey, how are you? How are everybody? I just entered. Sorry, I saw the very end of the case, but a beautiful case. I try to do the perfect as I can the hemostasis without leaving anything else inside. Like try to be as clean as possible, but making sure that there is no blood. That's what I think it's important, so you don't have deposit of hemosiderin. But of course, there is not something that you can really be sure of. In some cases, I do fill the cavity with fibrin glue, but I'm not sure if that is the best thing to do. I'm not sure.
Okay, thank you. So should we go on to the next case, or does anyone have anything to add?
No,
Professor
just one
Goel,
more
Abida.
comment. Can I?
Yeah.
One more comment.
Yeah.
If you can, one thing that if you can is to preserve the arachnoid and try to close it at the end. So you might avoid a little bit of the scar of the cortical with the inner layer of the dura. So this is a trick that Professor Yashargil and Professor Ture is always talking about. And it might also prevent, if there is no such attachment of the cortex to the dura, it might also prevent you to have some scar and some discharges. And the other thing that they also use is to always leave a thin layer of spogostan or some gelatin substance, also to avoid this scar of the cortex against the dura mater. So this, I think, it's a trick that might prevent you to have postoperative seizures.
Right. Thank
That's
you for
a
the
great
comment.
point, Paulo. I was lucky to be there with the, I was studying and reviewing 400 craniotomies for Professor Ture, in which he was placing, Paulo, this spongostan layer, and the results were very, very nicely exposed, because the tumors he had to reopen, in all of them there was a perfect layer separating and avoiding these meningocerebral adhesions. So I fully agree with you.
So should we go ahead with the next
Yeah,
case?
let's please go ahead.
Yes,
Let's please.
yes.
So the second case is a 37-year-old gentleman who had presented to us with one episode of a right focal motor seizure involving his right upper limb. This seizure had occurred 4 months prior to presentation to the hospital. Following the seizure, he had noted mild weakness in his right hand, as well as a mild word finding difficulty that persisted following the seizure until presentation. He did not have any features of raised intracranial pressure and no other gross neurological deficits. His MRI image again showed a fairly large T2 hyperintense, pretty well circumscribed tumor in the left inferior frontal gyrus that was but seemed to be compressing the putamen, which is shown here by the black arrow. So that seemed to be compressing and medially displacing the putamen. And also the internal capsule, the anterior limb here can be seen to be free of the tumor. Looking at slightly higher cuts of the same tumor, we can see that the tumor posteriorly abuts the precentral sulcus, and in the deeper cuts in the subcortical white matter region could probably be involving the deeper part of the precentral gyrus, that is the motor gyrus as well. There is no extension across the corpus callosum onto the opposite side. And a sagittal post-contrast image shows no appreciable contrast enhancement within the tumor. The tumor again appears to be very well circumscribed. Measures about 5.8 centimeters in maximum dimension.
So in terms of the anatomical location, I mean, you've got a 6 centimeter tumor there compressing the
Do you
area.
have coronal cuts?
No, for this case, we do not have any coronal images put up online, sir.
What exactly do you want to see on the coronal?
Well, actually, I do prefer to see the most anatomical pictures of the T1 with contrast and with the volumetric rendering also. It's very important for us to see the limits of the tumor. I don't trust too much in the T2 and the flare as to program or to make in my mind where is located this tumor. Because really the key of the surgery, or one of the keys of the surgery for me, is what I learned also, is to define precisely what is the origin of the tumor. So with the axial cuts, it's very difficult to imagine where they are, where is the origin. So the most reliable one, what I learned from Professor Ture and also from Professor Yasher, given in my experience, is the coronal cuts. And sagittal will also give you a lot of information. Axial cuts they are very confusing, especially because of the angulation that you might have depending of the technology or the technical guy that is doing the MR. So that's why I really rely mostly on the coronal and sagittal cuts.
Right, that's a good point. So in this large tumor, compressing that entire area, it was a little difficult to figure out whether it was in the pars orbicularis, but it looks like everything is compressed inferiorly, and that it may be just in the precentral sulcus. So now in this situation, I don't, compared to the previous case, I don't think there would be any doubt that we have to operate. Would anyone have a difference of opinion in terms of the size and the fact that he's now recruiting new deficits?
No, I mean, I think surgery is necessary.
Yeah, surgery is
Hey,
necessary.
hello, Abida.
Hi.
Great to have you on board. Yeah, so Ankush, what happened at surgery?
Yeah, so here this patient underwent a left frontotemporal craniotomy and a near total excision of the tumor. Intraoperatively, actually, we used dynamic white matter stimulation. What we observed was that in the depth of the tumor resection cavity, we did obtain some EMG responses from the contralateral limbs. And hence, we ended up leaving behind a thin sliver of tumor in the depth. Postoperatively, this patient did very well, did not develop any new neurological deficits. He continued to have a mild right hand grip weakness. So this is a immediate postoperative MRI or a T2 flare image, which if we look closely, we can see the resection cavity over here and T2 hyperintense, a slightly different intensity located in the depth of the tumor resection, which would point towards a residual tumor there. So the biopsy of this case was reported as an anaplastic astrocytoma, WHO grade 3 tumor. Postoperatively on follow-up, this patient underwent chemotherapy with temozolomide and adjuvant radiotherapy. And this is a 2-year follow-up flare image, which does not show any obvious gross tumor, and the patient clinically remains well.
So I think the important lesson here is the fact that even if you don't have an enhancing tumor, the tumor could be high grade. And an open surgery with an excision provided the pathologist with adequate tissue for all the molecular markers that are required, rather than just a stereotactic biopsy that some people do for eloquent area lesions. So I think in that situation, your strategy was good. Any comments from anybody?
Professor Goyal is here and Ibrahim Bey is here. Please, anybody who would like to comment on this, please.
Hello, can I comment, please?
Please.
Yes, please.
Yes, I'm Dr. Najjar from Syria. Hello, everybody. Hello, Paulo. How are you? I'm very glad to be here with you. Did you use the intraoperative ultrasound in the operation during this section? It will be so helpful.
Yes, we use intraoperative ultrasound on all our cases. Before dural opening, we locate the tumor and define the margins. That kind of helps us tailor the dural opening. And after the excision, we put the probe in again to see if there's any residual tumor. Sometimes it can be difficult if you have hemostatic material or blood, but we've got used to it over the years, and we find it an extremely useful tool, particularly since we don't have an intraoperative MRI or 5-ALA.
Well, it's a great because using it many times will help you during the stages of your resection. And something else also I noticed Professor Ture doing during operation, he waits in the cavity post resection for maybe 30 minutes just to be assured that there's no blood or bleeding in the tumor bed. He sometimes wait 30 minutes to be assured of no bleeding in such areas.
Yes, that's a good point. I'd like to ask Abida or Pablo a question, if I may, and that is related to these large tumors that are in and around the inferior frontal gyrus, compressing the Broca's area. How do you kind of analyze the MRI? Are there any tricks that you use? Because everything is so distorted.
I I guess the best thing first you do is try to identify from where is the exact location. Like we said, we see all the three axial, coronal, and sagittal. I try to identify the gyrus, the basic origin of the tumor from which around which gyrus it is around it. And depending on that, you then try to figure out which tracks are going to be in that gyrus or around that area. And that's how then you can go ahead and plan your surgery. And then, of course, you have to do the mapping intraoperatively. And yes, that is how I would do it. Pablo?
He's not connected at the moment.
So the other question I had for you, Abida,
Yeah.
was, the knowledge of the tracts is excellent for epilepsy surgery
Yeah.
and for approaches to the deep gray and the ventricle, right?
Yeah.
You know how to kind of avoid them.
Yes.
Now, for glioma surgery, how much attention do you pay to it for larger tumors?
Yes, I pay a lot of attention to it because when you're at the border of the tumor, when you want to go absolutely like go for a radical resection, that's where you're going to interact with your fibers. So if you know that there is something that you don't want to injure there, you will avoid going there. So in a large, what tends to happen is the fibers are displaced. They might not be infiltrated, they will be displaced. So when you're at the border of the tumor, to avoid injury, that's when you have to be aware of which fiber is going to be there. Like for an arcuate fasciculus, if your
Yes.
tumor is near the arcuate fasciculus, so you're like your maybe maybe temporal, not if you don't say frontal, but some temporal tumor, and you're near the superior temporal gyrus anteriorly. You know that your arcuate is going to be there posteriorly, probably displaced. So you when you reach your periphery, that's where you'll be careful that you don't overshoot your margin and damage the
Right.
fasciculus.
Yeah, so I was basically thinking about the superior longitudinal fasciculus because Pablo has a case which he's going to be discussing. Maybe we could talk to him about it also, about how much attention he pays to that.
Yeah.
Right. Any other comments, or should we go on to the next case?
Do you think that the functional areas will be in as islands intratumor in such anaplastic third degree, or it will be displaced outside the tumor, and you will be safe as much as you stay in the tumor, not like the high glioma, which you will find some functional areas in the tumor bed itself, as the Professor Yazagin theory. What do you think in such a case?
Well, I've done a fair amount of awake craniotomies on these cases, and I found that actually within the center of the tumor, I've never found functional tissue. But on the periphery, where the margins are infiltrative, then yes, you may find functional tumor, and therefore, if we are in an eloquent area, I usually leave tumor behind because I don't want to get a deficit. So on the edges of the tumor, you can have functional tumor function mixed with tumor. What do you think, Abida?
Yeah. I very like we had a case once where it was in the speech area, and we found function in the tumor, within the tumor. That is the only case that I have come across where we had to stop the resection because as soon as we started stimulating, the patient would have a speech arrest, and we were pretty much within the tumor, not even at the margin. That's the only patient I have seen where there was function within the tumor. Others, most of the time, yeah, you're right. It is at the periphery of the tumor. The most of the time, the functional area is pushed away.
One word of caution that our electrophysiologist warns us about is the current, the strength of the current. and that if we use the minimum current that's required to actually elicit a response. So if we do get a response inside the tumor, it's usually because we've increased the current a lot and then we reduce the current. But I agree, if you get a response inside the tumor, you can get quite unsettled.
Yeah, yeah.
Professor,
Polo,
I have a question.
yeah, Polo, would you like to comment? Polo, are you there? Professor Goyal or
Yeah, can you hear me now?
yes, 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 yes,
Yeah,
yes.
yeah, okay. And so now I'm connected. I know, Ari, you were asking me some questions I couldn't answer because, my mic was not working. So I have restarted the whole thing.
No problem.
As far as this issue of functional area within the tumor, as you were mentioning, like if the patient has no deficit, no functional issue, and you are removing the tumor, you know that you are in the tumor and the function gets affected. You see, that is the very important issue. And as Abida was saying about it, that more often than not, or maybe I will say always, the functional area is displaced by the tumor. And I will like to have opinion of Pablo and others what they think, because it has never really happened that the tumor actually engulfs a functional area. So this is a very important issue, and this is what makes awake craniotomy relevant. So I will like to know the opinion further on this issue. Ari?
No, you make an important point. I think Pablo's disappeared for the time being. But as you said, I have never had a situation where I've found functional tumor right in the center of a tumor.
Because that goes
Functional,
against the nature of
yeah,
these tumors. You see, uh, I was particularly curious about your first case, that smallish tumor.
right,
I don't know whether you are showing the big case that you had were showing, but even in small case or big case, this monitoring comes effective in the periphery of the tumor rather than
right,
inside the tumor.
exactly. That's our experience too. The first case actually was a pilocytic astrocytoma. So those are very well circumscribed and they don't infiltrate. But I guess if you have these diffuse astrocytomas that go all over the place, you could have a situation on the margin where you can have a kind of a
Yeah, yeah.
finger-like projection through, and therefore you need to be extremely careful at the margins,
And
which
that's
is why
where
I'm really scared. Sorry, go ahead.
that's where your monitoring and your awake
Right.
craniotomy and the thing will work. You see,
And yeah,
that is why these things are recommended. Like you do awake, you use monitoring, you use motor monitoring, and all these things are required because it happens, as you are saying, that
right,
finger-like projections and extension into the motor area happens, but uncommonly, not very frequently.
right. Which is why I was kind of wondering about the use of 5-ALA. I know that it's for high-grade gliomas. Pablo's got 3, 4 cases. Maybe once we get his case and he's discussing it, we talk about it again. Should we, Ankush, you want to go on to your next case? Ip, is that okay?
Yeah, absolutely, absolutely.
Okay.
Yes.
Okay, so the next case is a 21-year-old lady who presented to us 4 months following a focal motor seizure involving her right upper and lower limbs with secondary generalization. She did not have any symptoms of raised intracranial pressure and did not have any obvious neurological deficits at presentation. On a detailed neurological examination, we were able to elicit soft pyramidal signs in her right upper and lower limbs. Here, the T2 weighted axial MR image shows a very well defined spherical mass lesion located in the posterior frontal region, measuring about 3 centimeters in maximum dimension. It is very hyperintense on T2, and it's also surrounded by a T2 hypointense rim. which could signify the presence of hemosiderin in that rim. Marked in this picture are the central sulcus, which is shown in red over here. And so it's evident that there is some perilesional edema around this lesion, which does extend onto the motor cortex, abutting the tumor posteriorly. If we look at the normal side, onto the right side, we can see the superior frontal sulcus, which traces posteriorly and joins the superior frontal sulcus. So comparing that normal anatomy onto the abnormal side, we can see that would be the superior frontal sulcus and joining the precentral sulcus. And this tumor seems to be located just around that region posteriorly. So we had done susceptibility weighted imaging, which showed significant blooming within that lesion, which was suggestive of a subacute hemorrhage within that lesion. On the T2 coronal MRI, we can see that the lesion is fairly medially located. It abuts the cingulate gyrus inferiorly and also causes a mild degree of a subfalcine herniation of the cingulate gyrus. Here we have drawn the anticipated location of the superior frontal, the superior longitudinal fasciculus, which seems to be probably displaced inferiorly and laterally by the tumor.
So you thought it was what?
So our preoperative differential was most probably a cavernoma. In this case,
Okay.
because of that well-defined lesion with the hemosiderin rim and features of subacute hemorrhage within it.
Yeah, so the question I had actually for Dr. Goel or Abida was that since you've studied the white matter and the gyri so closely, the superior frontal gyrus, does it have secondary sulci running longitudinally, either on the convexity or on the medial surface? Or is it one clean gyrus?
Ari, now listen to this properly, okay? This we have
Okay.
recently studied in a very, very fantastic manner. And I will ask Abida to talk about that fibers that you are talking. Just Abida, go ahead. Because recently we have done quite remarkable anatomical studies. I wish she can show the anatomical studies that we have recently done. Go ahead.
Yeah, she showed it to us. I was very impressed.
Yeah, remarkable. And that is quite a fantastic thing. And only rarely it has been discussed.
Hello?
As far as, go ahead.
Yes, so basically on the surface, on the convexity, superior frontal gyrus does not have any additional sulci. On the medial surface, it will have some additional sulci. And where it is just going to join the precentral gyrus, that's where there might be some kind of a extra sulcus that is there. So there is always a good connection between your superior frontal gyrus to your precentral gyrus, always a very good connection that is there on the convexity, on your hemisphere surface. On the medial aspect also, there's a good connection between the superior frontal gyrus and the paracentral lobule. And otherwise, the superior frontal gyrus will also connect with your middle and inferior frontal gyrus by good connections.
Yeah, Ari, did you get that? You see,
Yes,
when you remove this
what she was
tumor-
saying was that the sulcus is not continuous in some places, and then there are connections between the superior frontal gyrus and the middle, as well as the superior frontal gyrus and the precentral gyrus, where there are good connections. But when you showed the coronal image, Ankush, just go back to the coronal. What you showed as that yellow line is the superior frontal. Then why is there one more sulcus seen up there? Just go medially on the convexity, that one. I was wondering whether that is, as Abida said, posteriorly you could have a secondary longitudinal sulcus on the superior frontal gyrus. Maybe that's it. Would that be right, Abida?
Yeah, maybe. I cannot see it very clearly actually. Maybe we'll have to zoom it, but yeah, it could be just a secondary branch or something like that. But generally there isn't.
Pablo is here. Pablo is back.
I'm here. Yeah.
Pablo, you're bang on time to start your first case.
Okay.
Now, do you want to present it or?
Sure. Whatever you
Okay. Go ahead.
I have 15, 20 minutes.
Please go ahead.
No, but
And,
Ari, did you finish this case? The cavernoma, did you finish this case? I mean, I don't think Ankush finished the entire case.
Yeah, but I don't think, is there anything more to discuss? We removed it and the patient
Yeah,
lived
nothing else.
happily ever after.
Yeah. Biopsy was reported as a cavernous angioma.
Yeah, that's what I mean. So yeah, good. So excellent.
But Pablo, I have to warn you that Dr. Goel and Abida have a lot of questions for you.
Oh my God, already I didn't start yet.
We have another question as well from one of our panelists, if I may present that.
Yes, please.
Yeah, it's from Dr. Louis Sevier, and he's asking that he's saying that it's an interesting lesion in an eloquent area. I would do a surgery with sedation and local anesthesia with neuromonitoring or navigation. What is your experience in surgery in awake patients?
Yes, we find that awake surgery in an appropriately selected patient is a really powerful tool. Sometimes when patients are not counseled adequately or if they are not cooperative, you could have a problem. But otherwise, most adults, and we've done some children as well, they're very cooperative and the surgery can be over within 2 to 2.5 hours. That's if you don't spend all your time on sightseeing tours and stimulating everything in the vicinity. So if you're there to do the job quick in and out, I think it's an extremely powerful tool.
Ari, there is
Pablo?
one more question from Samuel.
Amir, yes.
Yeah. Hello, everybody. I'm Samuel House. Actually, about the third case, because while description the axial section, the description was about peritumoral edema, and I think that was not the case when we just figured the coronal T2 also, because in the coronal T2 and also in this axial, it's more like a hemosiderin ring from the start before telling yes. And this coronal, maybe it's more typical of cavernoma with the hemosiderin rim surrounding the lesion rather than an edema. I do not suggest an edema surrounding the lesion as far as all the sulci are opened.
Well, I think Dr. Ankush was referring to this white on the left panel. Yeah, that white thing there.
Maybe this of compression, maybe, yes, it's not a small lesion. But
right.
I wonder if it's intra-op, because as described, it's in the histopathology, it was cavernoma. I think any
Yes.
clue intraoperatively for cavernoma, because it's different.
It has that typical, you know, the altered blood within the lesion, and then a mulberry-like surface, which you have to be very careful to take everything, because if you leave a little bit behind, that can bleed later.
Yes. That's the point. I mean,
Right.
if
Thank you.
intraoperatively you suggest cavernoma, so even this the strategy for surgical resection will be different.
That's right.
Yes, thank you.
Okay.
So we can start with the cases.
Pablo?
With Dr. Pablo, yeah.
So shall I stop my screen share then?
Yes, please. Yes, please.
Would you like to share your screen, Dr. Pablo?
Sure.
Yep.
I don't know which one is the first, so let's start. Most of these areas you have already been covering them, but we can reinforce some anatomical concepts, I hope. And this is, if I remember well, a 50 to 53 years old male who came with some personality disturbances and some seizures. And this is, I do have a CT scan, but in order to discuss the anatomy, I think the MRI is much better, so we can go directly to the MRI. And you can see the tumor is in the superior frontal gyrus, and it was finally a GBM. So the key in order to plan an anatomical resection, which is mainly the goal when we are close to anatomical and functional, relatively highly functional areas, is to identify. There was someone in the panel asking about how to identify sulcogyral architecture when we have a tumor which is distorting the normal anatomy. And I hope this is a good example of that.
If you have a look at the axial, I fully agree with Paolo Cadri, who was discussing which slices are the best ones in order to understand. And I do have the feeling that in order to know which is the lobe involved on the tumor, the axial for me is the one which is giving more information. Because here, for example, we can see the coronal suture, and we can see the clear anatomical structures on the right hemisphere. So axial is very good to locate this tumor in the frontal lobe. Once we know the lobe, usually the coronal is very nice once we are in the frontal lobe to see if we are in the superior, middle, or inferior frontal gyri. And it's clearly a tumor which is mainly located in the superior frontal gyrus, as we can see here. Here we have the first limit, which is the superior frontal sulcus. And the medial limit, obviously, is the interhemispheric fissure with the falx. Posterior limit will be the central lobe, and the anterior limit is not so clear. But if we have a craniotomy which is extending anteriorly and posteriorly to the coronal suture, we will partially expose both aspects of this tumor. And in the depth, it's very important in this case to identify this sulcus here, which is the cingulate sulcus. So here we have all the limits of this GBM. And to understand the anatomy in distorted anatomy, I think it was Dr. Hedman who was asking about that. What we do is, oops, sorry. Let me try to play this video. Can you see the video now?
Yeah, we can see that.
So this is a 3D reconstruction. You can easily do this 3D reconstruction with any software. This one was Osiris, which now is Oros. So we can see the tumor nicely, and we can see our limits. So superior frontal sulcus, interhemispheric fissure, and posteriorly we have the central lobule, which can be easily stimulated. So these are all the weapons we do have. We do have imaging, 3D reconstructions, our anatomical understanding, and finally we can check these findings with the motor stimulation. So again, after the resection, we can identify much better the anatomy. Superior frontal sulcus, cingulate sulcus, central lobe posteriorly, and anteriorly we are just based. We can use 5-ALA, or we can use our anatomical understanding. We can use the ultrasound, but in this GVM we can easily identify which is the healthy tissue. In this case, we use also some subcortical stimulation to make sure that the corticospinal tract was living intact in this most posterior region and deep area. So that's the first case, open for discussion. And I heard that Abida and Professor Goel have some issues to discuss.
No,
I actually had a, sorry, go ahead.
Go ahead.
No, please go ahead.
No, this is a, quite a well-defined tumor, and the anatomical landmarks are also beautifully defined as you have done it, and very close to central sulcus, motor area. So you have done a good job, Pablo. No question about it. Even if it is an aggressive tumor, you have done within anatomical profile, very good work.
So thank you. I wanted to ask you also if you have some clues about, this is a supplementary motor area lesion.
Yes.
Usually we are expecting, I do these cases without awake. I do them regularly asleep. But generally those low-grade gliomas, I don't know why, but generally in low-grade gliomas, we find this supplementary motor area syndrome after surgery. But in my short experience, this is much more common with low-grade gliomas. This patient, 6 hours after surgery, was completely intact in terms of motor and speech. And I have done some smaller low-grade gliomas in this supplementary motor area with the same resection, same landmarks, everything exactly the same. But in those cases, I found in many of them the supplementary motor area syndrome, but not in high-grade gliomas. I don't know if you have the same experience.
Okay. I will ask you one question, Pablo. Do you think this patient can develop speech problem? Yes or no? Say yes or no.
You mean after surgery?
Yes. See, this is quite away from the speech area, right?
It is. It is.
Yes. So I'm asking you one question. Do you think this fellow can develop, after this beautiful resection, speech problem?
Well, potentially.
Potentially,
can.
no
I don't,
don't think.
I don't think. But mutism due to the Aslan tract mainly has been described as a potential neurological problem after surgery. But I don't, this is something I don't expect to happen, to be honest.
So, you know, Pablo, there are some arcuate fibers, and arcuate fibers have connection with the inferior frontal gyrus, and that connection, even if you have not directly handled the inferior frontal gyrus, you can actually damage those fibers which connect from this area along the arcuate fibers, and you can have speech disturbance, motor disturbance following this tumor, following the premotor tumor resection. This is what I have a feeling, and some anatomical work we have done on this, and I hope we can show you some anatomical work regarding those connections.
Oh, lovely. Thank you. So Ari, Avida.
Yes, Pablo, we have also seen it in more in low-grade gliomas, as you were saying. Probably we have seen both the weakness, it's the classical supplementary motor area syndrome in low-grade gliomas more frequently than high-grade gliomas. And if you want, I can just show you some anatomical. This sir was talking about these connections, these short arcuate connections. I can show some anatomical images. Just give me a minute, okay?
Sure.
I think you will love to see those imaging, Pablo. You will just be very happy to see those images. Just see.
I'm sure. I will stop sharing, Avida.
Yeah. So I'm going to start share screen. Can you see my screen?
Yeah.
Yeah, so this is basically what I've done is just studied the short arcuate fibers in this region. So I'll just show you those connections that we were talking about. See these. Can you see?
Yes.
Can you see my screen?
Yes.
So this is the connection. This is from the superior frontal gyrus. This is the short arcuate connection. I'm calling this as the intergyral connection, that is connecting it to the precentral gyrus here. Then you have this connection of, this is a very, very, very constant connection. And it's not to be mistaken with the pli de passage, that is inside in the depth of the sulcus. This is a superficial white fiber connection. Basically your short arcuate connections between your middle frontal and your precentral. And these connections, these are the ones I'm talking about. This superior frontal, it's connecting to the middle and going all the way to the inferior. So when we are doing this supplementary, which is in this area, tumors in this area, supplementary motor area, that's when you damage these connections. When you damage this connection and this connection, I think that's when you get the deficit. And most of the time it recovers. It recovers because there are parallel pathways and circuitry that can take up the function. So this is what we have just seen. We have just studied the short arcuate fibers.
That's beautiful.
So that's what, yeah.
Thank you, Avida. It's kind of magic because you are expecting these patients to have this severe motor deficit, but you also expect them to recover nicely in a short term, in few days, even during their stay in the ward. And maybe that's the reason why it's mainly happening in low-grade gliomas, because the limits are not so clear, so we can damage some of those fibers, because we are working based on T2 and FLAIR, I guess, mainly with those ones. And
the deficits, Pablo, will recover. In these cases, the deficits will recover in a short period of time. That is almost always, and in about 1 month or 1.5 months, everything will recover in this area. That is a very common thing. Even speech deficit will recover. That is the beauty. And you will be very surprised to have a speech deficit, but they can happen rarely. And if it happens, it recovers. So that is the difference. But in this area, in the superior frontal gyrus, you don't expect speech deficit, but it can be a big possibility.
Yeah. Yeah, brilliant. Thank you. So we can go for the next case, and it's very, very similar area to the one that Ari and Ankush were sharing before. This is 76-year-old male who came to the emergency room, and the family was referring that the patient was having some speech disturbances progressively once. And when we explored him in the emergency room, he had a severe dysphagia. So this is a quite special tumor, because you can see it's not such a big one. And it was finally GBM. It could be a metastasis also based on the location and the aspect, but it was finally GBM. And the nice thing of this one is that it's growing in a very specific area of the brain. So let's start with the trick, and this is how I usually work. Based on the axial, I try to decide in which lobe it's located. And this is quite a curious one, because it could be frontal or it could be even subcentral. So if we have some doubts, we can go to the sagittal. So if we go to the sagittal and to the coronal, we will see it's in the inferior frontal gyrus, as we were discussing before. But in the inferior frontal gyrus, we do have different specific areas. And this one here, we can see this point, this cistern. This is the so-called anterior sylvian point right here. So pars triangularis is pointing at it. And then we do have pars opercularis. And behind the pars opercularis, we do have the precentral lobule and the subcentral. So this tumor could be in between this posterior limb of the pars opercularis and the most inferior or lateral aspect of the precentral gyrus. This is the so-called dorsal preventral, motor preventral area, which is just in between these regions. And it's very important in the dominant hemisphere for the nomination, for the speech function. So again, in these cases, we do have to do this reconstruction, 3D reconstruction, so we can see where the tumor is located. And the patient was, he had some comorbidities, and he had dysphagia. So it's in our hands, it looks like nonsense to do an awake surgery, because we are not gonna offer anything to this patient, and we are gonna be in troubles. We cannot check the speech function in a patient who is already severely disabled in this aspect. So this is the small exposure we are doing. This is the sylvian fissure. So this is frontal, and this is the junction in between pars opercularis and precentral region. This is indeed the precentral sulcus with this precentral artery here. So we decided to do a pure tumorectomy, and for tumorectomy, and this is something you were asking, Ari, before, if we do have any trick to try to avoid seizures. I do not have, because I don't know if there is any science on that, but obviously hemostasis is very important. And for me, the most important thing is to try to stay within the tumor and to do a nice subpial resection and to use the bipolar at the minimum. So we try to avoid bipolaring as much as we can. So we do this incision in the pia, and we try to coagulate these aberrant vessels, which are clearly going directly to the tumor. So we push the pia, and in this case, we were using 5-ALA, which is very helpful in these small tumors in highly eloquent regions. We take some tissue for diagnosis, and then we try to avoid bipolar. So we do subpial resection based on anatomical landmarks again, and based on the 5-ALA. So in this very highly eloquent region, once we are sure that the fluorescence has gone and we have exposed precentral sulcus posteriorly and the so-called diagonal sulcus anteriorly, sylvian fissure laterally and inferior frontal sulcus medially and superiorly, we stop the surgery in this case. Patient had a complete aphasia during 6 hours after surgery, and 24 hours later he came back to his normal speech fluency, which was very poor indeed. But in the pre and post-op images, intra-op images, we can clearly see and understand much better the anatomy. So here we do have the sylvian fissure. Now we have the precentral sulcus posteriorly, inferior frontal sulcus medially and superiorly, and the so-called diagonal sulcus anteriorly, which is a sulcus which is not always there, but when it is, it's separating the anterior from the posterior limb of the pars opercularis. I don't know if you agree with this anatomical explanation. I would like to know your opinion.
Pablo, both Ankush and I were quite impressed with this case. We had a couple of questions for you, and that is, when you are not operating on the patient awake and you're not stimulating, how do you decide where to do your corticectomy? Because you went onto the posterior portion of the pars opercularis. Whereas if I was not monitoring, I would have done an ultrasound and gone anterior superior so that I'm as far away from Broca's area as possible. How did you make your decision about where to start the surgery? Once you get into the tumor, it's different.
So this case, this is why I share this one, is very special, because I cannot imagine a highest eloquence into the brain than this area here. And this is why I share this one. Generally, my point is, what I learned from my professors is to try to find which is the most superficial part of a glioma, the most cortical aspect of any glioma. Generally, it's said that gliomas, when they start growing, when they start developing, they don't cause symptoms because they don't destroy the fibers. They just take advantage of the fibers to grow. So this one is very special because it's a small one and it's a high grade one, and it's growing in the highest eloquent area of the brain in my mind. So as I couldn't monitor this patient in an awake fashion because of the severe deficit he was having, I just wanted to enter in the most cortical part, because obviously this tumor has destroyed that region. It's obvious. Right. It's a kind of compression or disturbance. It's a high-grade glioma which has destroyed that area. And the post-op course gave us that reason, because the patient was exactly in the same status than before surgery. And this is how we do that. Okay. In most of the cases, we try to go to the most superficial part. And in this case, I don't know if you saw the beginning of the video, with high magnification, this is kind of science fiction if you want, but I truly believe on that. If you high magnificate, you can see the normal vessels of the brain in different gyri, but you can see, look at this vessel, this aberrant vessel. Yeah, they are clearly abnormal. Yeah. This is giving you some information that the tumor is there. We use the ultrasound, obviously, but this one was very, very, very small one. Right. So it was clear it was there.
I got a little worried. I thought under high magnification, you saw mitotic figures over there.
Next step. Yeah. I had a professor who told me that you shouldn't use too much magnification because the microscope is magnifying your problems.
Yeah. Actually, Ankush had a question about the subcentral gyrus and the, what other sulcus was it, Ankush?
No, I think Dr. Pablo, in I think your previous case, you've got an anatomical picture which actually describes this diagonal sulcus.
Diagonal sulcus.
And
can you just show it on that lateral view of the brain?
I think,
yeah, the one above that, yeah.
Oh, sorry, it was the end of the case. So the tumor was growing in this very capricious area of the brain. So let me review with you the inferior frontal gyrus. Pars orbitalis is far away of it. It's right here because we have the anterior sylvian point, if you remember in the sagittal cut, where we were showing this anterior sylvian point. So this is something very key to find in the sagittal cut. So once we find that one, we can see pars triangularis pointing at it. So if we follow the pied de passage, we will find the anterior limb of pars opercularis, and this is a U-shaped gyrus generally, which has the anterior and the posterior limb. So in between them, I don't know if there are different names, because in anatomy there are so many different names for the same structures, but this is the name I found: diagonal sulcus, separating the anterior from the posterior limb of the pars opercularis. And pars opercularis generally is connected through this pied de passage, which can be superficial, it can be hidden in the Sylvian fissure, or it can even be hidden in a subsulcal region, but it's generally connected to the precentral gyrus. So this is the so-called ventral precentral intersection area, and I guess this is mostly the location of this tumor, where this tumor was growing.
Yeah, that's good. That is quite clear now.
Okay, so we have another question from one of the panelists. It's from Rakesh. He needs to know that, so where do we start from, based on most superficial part or tumor of the tumor, or awake monitoring in such cases, in such a highly eloquent area of a tumor?
Well, I think there is a big difference when we are doing an awake craniotomy, especially for this region, because mainly we base our cortical entry and the cortical decision about where to start the resection based on the function we are finding. And this is what Ari was highlighting before. This case was basically what we wanted to do. It was a pure tumorectomy. We didn't want to go and to extend to a supra marginal resection. So if we are doing, imagine we are doing this case in awake, under awake conditions, and we start stimulating absolutely everything around it. So it could change our decision. If we don't find any function anterior to it, we could go anteriorly. But I guess we wouldn't have found any kind of response in this area, because the tumor had already destroyed this function. So in this case, awake craniotomy wouldn't have added so much. Maybe we could have had some information about the motor strip, which was just posterior to it, but I don't think in terms of speech we could have found any other clue to guide our resection.
Right. I mean, the point is that if you are not operating on the patient awake, I mean, I guess a 76-year-old person, to do him awake is quite a challenge. But if you do this under general anesthesia, then I might have chosen to go into the tumor through the posterior end of the inferior frontal sulcus. But I don't know whether whether it would have displaced the Broca's area superiorly. It can do that, I know. But when you're not monitoring, I wonder whether that is generally a safer area. I know that Ogeman has done many cases under awake and correlated it with the functional MRI and shown that most of the speech arrests occur in the inferior part of the pars opercularis and the posterior part of the pars triangularis, whereas the superior and anterior parts seem to be the safest. Of course, it's not 100%, but I may have chosen to go through the inferior frontal sulcus. That one of the audience had asked this question. So would you say that's acceptable, Pablo?
Well, I think so. So. But generally, even if I do awake and I check that this part I told you about, the most superficial extension of the tumor, even if I check that under awake and I find no response there, I would go through the cortical extension. I would avoid
that. I agree. I agree. If you have got stimulation evidence that there's no function, then that would be a good place to go.
I will always try to go through the more superficial part, because it's theoretically the part of the brain where the tumor started growing. I guess.
I just wanted to bring up one point for the viewers in our part of the world. When you have a small lesion like this, less than 2 centimeters in size, one of the differential diagnoses is either a tuberculoma or a cysticercus granuloma. But this is only in patients who have seizures and who do not have deficits of mass effect or raised ICP. So we have to get a histological diagnosis if any of these are present in a lesion less than 2 centimeters. And I presume you never even think of this possibility, Pablo.
I never
Your
saw.
decision-making process is easy.
I never saw. Okay, so let's go to the third one. Third and last one. This is a, 49 years old, a man who presented into the emergency room with progressive personality disturbances and a history of mild headache for the previous 3 to 4 weeks. So this is what we found. And this is cingulate gyrus lesion, not exactly frontal lobe, but it's related to the frontal lobe because we can choose a transcortical transfrontal lobe resection to it. So this is why I wanted to discuss this case with you. And this case, and well, it's very important to have a look at the images because we can get many information from it. We could say that if we don't pay too much attention, that it's crossing the midline through the corpus callosum. Do you agree with that? So it could be, but if you analyze, and I cannot share with you all the images, but if I show you a T2, axial T2, you will see that this is the corpus callosum. So this is the supracallosal sulcus. So the corpus callosum is pushed posteriorly. Obviously, it's infiltrated in the ipsilateral side, but the tumor is not crossing the midline. It's crossing the midline anatomically, but not through the fibers. So this part of the tumor into the right side, it's part of the left cingulate gyrus, which has been growing and it's crossing the midline below the fibers, but it's not invading the contralateral cingulate gyrus. It's just a matter of mass effect. It's pushing the contralateral hemisphere. And this is the crossing of the midline because this is the corpus callosum. I don't know if I explained my thought properly, if you agree with that. This is corpus.
It's quite clear what you're saying.
So this tumor is mainly growing.
Do you look at edema on the opposite side?
There was some edema. You can see it not very well here, but in the T2 you can see it right here. So this is a glioma, high-grade glioma. So obviously it's very possible that there's some infiltration already through the corpus callosum. But I'm talking about the enhancement of the lesion, which is the part of the tumor we really want to remove in case of surgery.
Pablo, you have some sagittal or coronal, some other sagittal image? Or
I do have for sure, but I'm not sure if I, yes. So this is the sagittal cut. It's not very good, sorry.
Okay, it's not.
I did prepare. But what I wanted to highlight on this case, that this is mainly a tumor growing in the anterior cingulum area. So these tumors are mainly growing like this. These are wrapping around the rostrum and genu of the corpus callosum. So they are located in this region. And when we have a good chance in the initial growing stages of these tumors, we can get the tumor mainly on the ipsilateral hemisphere. So in these cases, in most of these cases, we are very comfortable if the venous anatomy it's favorable. We like to do a contralateral exposure because you can see here we are placing the right hemisphere in the ipsilateral exposure. So we will split the interhemispheric fissure in the right side and we will try to get the tumor just in front of us. So it's the same concept I was highlighting before. We try to always identify the most superficial part of the tumor, and it's obviously here. So this is why we want to go through the contralateral side in case the venous anatomy is favorable. There are, in my mind, many advantages. One of them is that we are dealing with a healthy hemisphere, which is not edematous. So the opening of the fissure is usually easier. And this kind of semilateral position is very comfortable also because we are gonna open the interhemispheric fissure in the direction of our hands movement. So we can use both hands much better than placing the patient in a neutral position. And let me show you that. In most of these cases, opening the falx will offer us a better anatomical understanding, because we want to control the cingulate sulcus, which in this case is superior to this tumor. So this is the midline. These are the bar holes on the superior sagittal sinus. So this is the right frontal lobe. And this is the important thing, to identify this venous bridging anatomy. And once we are there, we start releasing some CSF if it's possible. And we try to open the falx to go to this most superficial part of the tumor. So this is the most cortical aspect. That's where we start doing the cortisectomy. And then we are identifying the cingulate sulcus, which is right here. The weak point of this approach is the roof of that cavity. But with the use of the speculum, we can even check that there was some remnant in that superior part. So once we finish the resection, we can see the anatomy much more clear. We have opened the falx through the right interhemispheric fissure. This is the left frontal lobe, medial frontal gyrus. So this is the cingulate sulcus, which has been wrapping around the corpus callosum. And we can even see the ependyma. I don't know if you can see that ependyma. That's the frontal horn of the lateral ventricle. So we replace it, and this is how it looks like. Sorry, it looks like after surgery. And this is the wide opening of the fissure we do have if we place this patient in a little bit semilateral position. This is why I feel really comfortable with that. And with this, we can reach much easily the most lateral part, but the problem is here in the most superficial, in the most superior part of the tumor, where we don't have direct view of this extension. And probably we left some tumor there, and also that tumor which was in the ipsilateral corpus callosum. So that was it. Open to your criticism about this approach.
You're waiting for everyone to jump down your throat.
Yes, I like.
You want to go first, Avida?
Henry Schroeder is here.
Yeah, hello everybody. Sorry for being late, but I was still in the department. Paulo,
Hello.
Beautiful.
Guten Abend.
It's a very beautiful surgery, and it's exactly what we do. We bring the contralateral hemisphere down, so we have not. We always place the head horizontal, that the falx is horizontal to the ground, and then the hemisphere is falling down. What we do in many cases is to make a pre-op lumbar drain, to have early release of the pressure, because sometimes you have a lot of edema, it's not much space. But then you have it shown very nicely to go to the contralateral side and resect the tumor without touching the left frontal lobe, which is always our intention. We use an endoscope as 45-degree or 70-degree to see to the roof, what you have shown with the mirror. But basically, it's the same. Beautiful surgery. Thank you so much for sharing.
Thank you, Henry, for your comments. Thank you. I tried it with the endoscope, but we don't have a fluorescence source in the endoscope. I know there are some with that technology, and this is why we felt more comfortable with the mirror. But I think to do it with the endoscope is the future. It's key in my mind. Thank you, Henry.
Pablo, I would have done it ipsilateral interhemispheric, not contralateral. That's the difference. I mean, I guess it's what you're more comfortable with. We are more comfortable with the ipsilateral approach rather than the contralateral approach. Just the difficulty will be in retracting the brain initially, but once you manage that, then once you're within the tumor and you start decompressing, then it's easier, I guess.
You know, Pablo. Hello.
I don't agree. I think if you look from the you need much more retraction. So I think the contralateral is much better because you have the oblique view to the tumor. If you come ipsilateral, you have to retract much more to see the lateral part
Lateral extension.
in the frontal lobe. Yeah.
Hello.
Oh,
Oh, we have Dr. Atul Goel. He's trying to connect. I think his connection is distorted.
Pablo, can you hear me?
yes, perfectly.
Until
Hello.
Dr. Atul fixes his mic.
Pablo, can you hear me?
Now I can.
Hello.
Now I can.
Pablo?
Yes.
Yes, yes. Pablo, can you hear me?
Perfectly.
Hello.
Yeah, go ahead, Dr. Goel.
Pablo, can you hear me? Yeah.
I can.
Pablo, you know, the question is about contralateral approach to, yeah, the question is about contralateral. Hello. Oh, Pablo.
Your voice is not coming clear, Dr. Goel.
Now it is coming.
No, it's not. It's not very clear.
Okay, so I will have to redo it now.
Now we can hear
Now it's
you.
better. Now it's better.
Now, Pablo.
Yes.
The question is about contralateral transfalcine approach to these tumors. This is the question.
Yes.
Okay. Now you tell me who has described this approach.
Oh,
Do you know?
I missed the question.
The question is contralateral transfalcine approach to the other side tumor.
Yes.
Okay. Now can you tell me who has described this approach first time in the literature?
So I'm not sure, but I would say Professor Goel.
You are correct. I had described this approach for the first time in the literature. Okay. Recently, you know, for these tumors which are going so much on one side, I prefer ipsilateral approach for these tumors. For this particular tumor, I would not have come from the other side. I would have come from the ipsilateral side. You know, retract the hemisphere and enter in, get to the tumor and, you know, get the bulk of the tumor and then go to the other side along with the tumor. Pablo, this would have been my strategy, but of course I will not, you know, this contralateral approach is my approach.
Thank you. We are losing you again.
Yeah.
I'm happy that you did it.
Thank you. So nowadays, mainly
Okay, Ari, you go ahead.
Sorry.
Yeah, Pablo, that is really an elegant case, and even the post-operative image looks great. I was just kind of concerned with the volume of tumor in the left frontal lobe, the extent that it was going laterally, the amount and the edema. So you've already got a damaged left frontal lobe. Now you go in through the right side and you take a vein and you have a post-operative venous infarct on the right side. And then you have a patient with bifrontal damage on your hands. Now, this may happen in 3 to 4% of cases, which means if you do 100, you're going to see 4 or 5 patients. So I was just wondering whether, when you said that you look at the venous anatomy, what exactly did you mean?
So this is what I was ready to add to the discussion. But nowadays, mainly, I decide the approach. Whenever I want to go contralateral, I decide the approach only based on the venous anatomy. And it means that I do a MRI venography. So I decide in which side I will have a wider corridor in the interhemispheric fissure just at the level of the tumor. Even there are some cases in which in both sides, and this happens mainly in the central region. This is an anterior cingulum, but when you are dealing with the central cingulum, generally, unfortunately, we do have on both sides some very uncomfortable venous anatomy. So in those cases, I do the craniotomy anteriorly, and I just oblique the direction of the interhemispheric fissure splitting. But it's always about the veins. I try to preserve them as much as I can, even in some cases, it takes much more time to dissect properly those veins and to open the fissure gently than removing the tumor. So I can tell you, I spend more time on that work, just trying to preserve them. And in some cases in which they are holding and they are quite narrow due to our maneuvers, what I have learned from some colleagues is we do place a very thin layer of a spongostan on them, and we put some glue to protect them.
There's a question from the audience from Dr. Altaf Ali. He asks, how do you manage a midline vein draining into the superior sagittal sinus? I presume he means that in the middle of your opening, you've got a vein draining into the sagittal sinus. How do you open the dura? How do you manage that?
So there are many kind of venous problems when you want to expose the interhemispheric fissure. Sometimes you can find a vein which is cortical, and then 1 or 2 centimeters before reaching the midline, it goes inside the dura. Those cases you can just cut the dura around it. So imagine we do have it in the middle of our dural exposure. What I do is I just cut the
Yes.
dura on both sides, and I leave it there so I can work on 2 windows.
Right.
Another common problem is that vein which is just in the middle of your exposure, but it's not inside the dura. In those cases, you can deal with it cutting the arachnoid around it and let's say liberating that vein from the arachnoid so you can create more space. And those are the cases in which I use this spongostan and fibrin glue.
Right. And then you spend the rest of the day closing dura.
Yes.
There's another question from the audience. In these days of supramaximal resection of gliomas, what is your opinion of doing a left frontal lobectomy on that case that you showed?
I understand that they are talking about the first case.
You're talking about this case.
This case, left
frontal lobectomy. I mean, they leave the inferior frontal gyrus intact.
Generally, everything with the word lobectomy, I don't like for glioma.
This is from Dr. Juan Carlos.
Yeah, again, I cannot talk on scientifically proven results, but I don't do lobectomies generally. Because if you saw what I generally do with gliomas, I try to go for tumorectomy, and then if I can, I extend the resection on the peripheral regions. But I don't do lobectomies. I don't do lobectomies by definition. I don't believe.
I guess you're right. With chemotherapy and molecular targeted therapy, I think these radical surgeries like a radical mastectomy, all those are gone. I think the same thing is going to happen here.
What we are doing, unfortunately, we are doing extended biopsies generally with gliomas.
Okay.
I would like to interrupt here, but we are just running short of time and we would like to wind this up. We will just take a question from Palak Jaiswal, and I wanted to ask, what about doing a small corticectomy on the anterior part of the superior frontal gyrus and do the.
That's something that could be also very nicely performed, but again, it's against the point of preserving the healthy tissue. But I do agree that this could be much easier. We can go quite frontopolar and going inside through the most anterior aspect of the superior frontal gyrus, safely reaching that tumor. I do agree with that also.
Thank you. We have, yes, Dr. Abida, please.
Yeah, but then you go through the SLF, the medial part of the SLF. So I think an interhemispheric is the better way to go to
No
preserve.
doubt.
Yeah.
Is the patient going to miss that SLF?
Yeah. Maybe not in a daily routine life, but something will go. Some perception, some spatial recognition, some deficit is going to come.
We have Dr. Ibrahim be with us. He's kind enough to reschedule his webinar, which was clashing with our time. So I would just want him to put a comment on this webinar and express his opinions. Cases. Dr. Ibrahim.
Okay. Good evening, good morning, whatever time is, and I'm going to present the brain tumors that one sees in cases of tuberous sclerosis. I was fortunate to have 11 cases in about 4 or 5 Jordanian families. So that would be to discuss.
Yeah, so we have Dr. Ibrahim in his next webinar, and we will be closing up this webinar in a few minutes.
Hira?
Yes.
Yeah, so before closing, I would like to tell all of you, well, all of you who participated, thank you, Pablo and Ari, excellent job. And so this is more of a neurosurgical magazine with a webinar attached to it. So we're going to have a main session, which is going to discuss distinct problems. Like, for example, today we discussed 6 gliomas of the frontal lobe. Now, in this magazine, we also have a quiz on DSA anatomy by Joy, a general quiz by Samer. We had some photo features and a fantastic editorial by Professor Goyal, one of the best editorials I've seen. And well, we have a section on innovation. This is something that we call a water knife, which helps to dissect the tumor, which helps to do hemostasis in aneurysm surgeries, to wash away the blood, to clear the field, all that. So that's an innovation. That's we're trying to promote very cheap and very practical innovations that's going to help neurosurgeons. We need your opinions on each of these. So Ignite is going to bring out every month a relevant topic. Like for the next month, we're going to bring out the temporal lobe. So this time it is a frontal lobe. We'll be bringing out the temporal lobe. So we are inviting articles from everybody all over the world. Now we have very noted neurosurgeons from all over the world here. So we're going to have a parking space where we're going to invite all these articles and park it there. And whenever the right time comes, we're going to put it across. We're going to put it on as the main part of the journal. And after that, the next month, we're going to have a discussion where people from all over the world discuss these cases. And it's going to be really helpful for the young neurosurgeons. This is the idea of Ignite. So this way, we're going to turn the young neurosurgeons who are presently interested in p-values and statistics into people who are really scientifically oriented to operative neurosurgery, which will translate to better results and better results for patients. So this is our idea, to turn an entire generation of neurosurgeons from pseudoscience to real science, which is actually neurosurgery. So, I mean, this is very clearly depicted in that editorial. I mean, I want you guys to read that editorial once. And once more, thank you very much to Ari, Ankush, Hira, Samir, our illustrator, Waralex, who's done a fantastic job. I mean, her talent is unmistakable. I mean, you must see. And I thank all of you guys, Polo, Pablo, Henry, all of you for coming in, all the other guys, and the residents as well as the young neurosurgeons for coming in. And then Ignite is going to have its second version coming out by August 3rd. So it's going to be a fun magazine, and it's not going to be, I don't like the word journal now, because journal is too scientific and it's not fun. What is life without fun? So neurosurgery has to have some fun, and Ignite's going to provide it. So we're going to have photo features. We're going to have crosswords by Samir. Excellent initiative by Samir there to put some crosswords, to put some quizzes and things like that. So thank you, everybody. We are very grateful to everybody who helped us with this.
Thank you, everyone. And if we have any more questions which are still following in the chat, you could message us on our WhatsApp or Facebook, and we will entertain them on the website. So stay tuned with us. Thank you, everyone. Thank you, professors. Thank you for your participation. Thanks, John.
Thank you, Hira.
Thanks.
Bye-bye. Have a nice
Bye.
evening. See you soon.
Bye-bye.
Okay, we're stop televised. Okay, we'll see you at Dr. Sabea's webinar, which the link is in the the link is in the panel in the chat room for you guys to see. So we're going to end this, and thanks everybody for coming.
Thank you, John. I'll go now. Bye.